Okay. Hi, I'm Lynne Mofenson. I'm representing the Elizabeth Glaser Pediatric AIDS Foundation, formerly of NIH. And this session is going to be on pediatric HIV and prevention of mother-to-child transmission. And we have three eminent guests. I'll let you introduce yourselves.
I'm Athena Kourtis with the Centers for Disease Control and Prevention.
My name is Julia Kenny. I'm a paediatrician based at the Institute of Child Health and the MRC Clinical Trials Unit in London.
And I'm Barlow, a pediatrician working at Makerere University, Johns Hopkins University Research Collaboration.
Great. So I think what I'd like to first ask each of you is to say what you think are the most important messages that you got from Pediatric and PMTCT during the meeting, and then also to talk a little bit about your own research that you presented. So you want to start, Athena?
Sure. I think that there was quite a bit of interesting data that we presented at this conference with regards to pediatric HIV. And some of the most important results that came about are the first results from the PROMISE impact trial, which was a randomized clinical trial of over 3,500 mother-infant pairs, randomizing into two approaches. And a ZDV-based, option-based approach versus a triple drug-based approach starting at the beginning of the second trimester, at the end of the first trimester, around 14 weeks of gestation. And we heard yesterday the first results of that study showing that the reported results on the 2-week transmission rate, and it showed that there was significantly decreased rate of HIV transmission to the infant with a combination, maternal combination regimen, which I think is not unexpected, but nevertheless important result. And I think it also is interesting when you compare it with some of the previous studies that had compared this approach starting at later points in gestation, and some of them, not all, but some had not shown a difference with the two approaches. I think it also highlights how important it is to start early in pregnancy.
Yes, yeah, totally.
The other interesting finding from that study was that there was a higher rate of adverse events with a triple drug, mainly preterm birth, but not very preterm birth. So that is something that we definitely need to be watching. There has been some evidence from the literature, not quite all of it agreeing, but I think definitely this is something that we need to be very cognizant and monitoring as we move forward. But now the regimen that is recommended globally is a regimen that contains an NNRTI, so it's not quite, it may not be quite comparable, but with these findings, but nevertheless something we need to be monitoring.
Yeah, I think it was pretty exciting. It's actually the first randomized trial data to support the WHO guidelines. So that's very good, but I agree with you that we need to have some caution in terms of potential adverse events with the three-drug regimen.
Another point from that study that was perhaps a bit unexpected to me was a higher rate of infant death in the group that received tenofovir FTC combination compared to the group that received AZT and 3TC. And it was mentioned that most of these deaths were among preterm infants, but again, this is again something.
Yeah, it was a sub-analysis of the data, so the comparison of the two triple drug arms, one with Condavir and one with Truvada, was only a subset of the study. So I don't know that you can necessarily draw any great conclusions, but it certainly does raise issues that need further research. Julie, do you want to say what you found?
I mean, yesterday's session, the pediatric session, I think all the presentations were fascinating. It was nice seeing the PROMISE results. I presented my own research, which was looking at cardiovascular effects in the CHAPAS-3 study. And the CHAPAS-3 study was a randomized controlled trial set in Uganda and Zambia, and looking at different first-line fixed-dose combinations for pediatrics comparing zidovudine, abacavir and stavudine, and as part of that I did a sub-study looking at cardiovascular damage in children who weren't yet on treatment and children on treatment, and we found even at a young age of 2.9 years that the children had detrimental changes in their cardiovascular system. But reassuringly, once antiretroviral therapy was started, after 2 years we could reverse those changes, and it didn't matter which arm they were in, given the concern about abacavir in the adult population and its association potentially with cardiovascular disease. I was also it was nice to see the results of the breather trial being presented. Yes. That was again a trial I was heavily involved with, and this is looking at efavirenz-based antiretroviral therapy, and in the adolescent population, giving them the opportunity to have 2 days off treatment. And very exciting, we found this is non-inferior to continuous treatment, and our adolescents really enjoyed having that freedom of having the weekends off. So I think that is exciting that we've got different ways of trying to engage our adolescent population. So both of those were quite exciting. One thing I have found about this meeting is the stark realisation that still only 23% of children in need of antiretrovirals are receiving it. And I think it's a timely reminder that we really need to work on getting out, finding the children, getting them tested, and starting antiretroviral therapy. And I think messages from CHAPAS-3 and other trials is children respond well to whatever treatment's available. It's identifying the children, getting them on treatment.
Yeah, I think that's definitely true, Liz. I think the pediatric portion, to me, really emphasized the importance of early treatment in children. Yeah. There were a whole series of studies addressing that, including SHARE, which showed early treatment with sustained suppression results in lower reservoirs. Mm-hmm. Your data showing that you can actually reduce and prevent cardiovascular disease. And then there's some posters. There's a poster suggesting that early treatment will give HIV-infected kids more normal pubertal development, because delay in pubertal development is associated with HIV, and normalized growth, so that there's more than just one reason for early therapy. And Linda, you presented an important study.
Yes, we presented the long-term outcomes of the P1060 study. Basically, these were children who were started on ART between the ages of 2 months and 3 years. And we're now 5 years out and seeing what the long-term outcomes were. The children were randomized to receiving either lopinavir-based or nevirapine-based ART. And what we found was those that were randomized to lopinavir-based ART remained on first line for much longer than those that were on nevirapine. So about 84% of those who were randomized to lopinavir are still on first line, compared to 52% who were on nevirapine. And in general, the children are actually doing pretty well compared to where they started. Most of those who are still on the study actually have non-detectable viral loads, so it supports early initiation. I think the issue now is whether or not we can actually get lopinavir to more areas.
Yeah.
Because even though lopinavir has been shown to be superior to nevirapine, there's still an issue of access. There's the issue of storage. So in rural areas where we don't have cold chain, the children are actually being still started on nevirapine just due to logistical challenges.
So the data in 1060 basically were the reason why WHO modified their guidelines to recommend for children under 3 that starting with a protease inhibitor was better than starting with nevirapine. And so now you've got data going all the way out to 5 years showing that this remains true, and that it is the concerns that there were that people were not going to stay on lopinavir because it tastes terrible, actually were not true.
Yes. Yes.
And there had been some concerns around CD4 count and growth, that might have been better with nevirapine than lopinavir?
Yes, initially there were some suggestion that the children on nevirapine had better growth in CD4, but 5 years out, that difference in CD4 has disappeared when you compare the two arms. However, when you look at weight for age, There is still a difference between those who are on nevirapine, with nevirapine being a bit higher weight for HC score compared to those on lopinavir. However, that difference is not statistically significant at some point. Though I think it's an area that we probably need to look at a little further as to the reasons why. I don't think we're sure of exactly why that difference is still there.
I think it's because it tastes so terrible.
Yeah, so it may be the palatability, or there may be some other reasons, but I think it would be interesting to see if this difference still continues. The children are going to be followed out for another 2 years, and we should be able to maybe make a conclusion, or...
Yeah, but I think also, aren't you looking at neurodevelopment in these children?
Yes. There is a sub-study in 1060 where we're looking at the neurodevelopment of these young children. Basically, the neurodevelopment study is going to assess whether or not children who were given nevirapine versus Kourtis have differences in their neurodevelopment, and this is based on the characteristics of the drug. One drug has better penetration to the CNS, and that may affect or improve the neurodevelopment in one arm. However, it's also important to compare that development to HIV exposed and HIV negative children. So the comparison will be done, and the study's ongoing, and hopefully in the next year we should have some.
CROI.
Yes, we should have some preliminary data.
Good. I guess I wanted to ask folks about drugs, PK, any new drugs in children. I think one of the things that CHAPAS is doing, aren't you guys looking at the mini pill formulation of Kourtis?
Yes, so CHAPAS 2 looked at the sprinkle formulation, and there's a poster here presenting those results. Again, it's carers preferred the sprinkle formulation, but we've still got issues with the taste even in the sprinkle formulation, unfortunately.
Yeah.
So certainly the sprinkles work, but the children still find the taste.
I think DNDi is developing a new formulation that's like a powder that will contain all of the drugs, so that you would be able to have AZT, 3TC, lopinavir, and ritonavir in one powder that you could just give. I don't know what the taste is, but that would, I think, certainly be an advance to be able to get the drugs out to the community, because you wouldn't have to have a cold chain. It would be easier to transport.
Yes, it would definitely improve coverage.
In CHAPAS 3 we used Favrin's tablets of 600 milligrams, which were scored once on one side and twice on the other side. So adult tablets could be used, and depending on how you break them, you can either get 300 or 200 milligram doses. And in CHAPAS 3 they were liked and useful as well, trying to align with
the guidelines.
And adult formulations. If you've got a pediatric stock out, you can use the adult tablets as long as they've got the stock that they're scored ones.
That would be nice if the company made it that way.
Yes.
Athena, I had a question for you related to, there were a couple of papers related to PMTCT I thought that were interesting. One was on the fact that we're not identifying HIV-infected breastfeeding women, and these women have a high CD4 count. And the other I thought that you might comment on was the infant diagnosis and potential delay in being able to diagnose HIV if the infant or the mother is receiving antiretrovirals, and how long do you have to wait until after they stop?
So this was presented yesterday by the RCDC group. The data were from the breastfeeding antiretrovirals and nutrition, the BAN study that was conducted in Lilongwe, Malawi, and that was a randomized clinical trial of over 2,300 mother-infant pairs that looked at the efficacy of antiretroviral prophylaxis during breastfeeding to the mother or to the infant, and showed them both to be very effective. So when we looked at the timing of infection, so in the study, the infants were breastfed for 28 weeks, and after that time they weaned. But we saw that there were some more infections that were acquired between 28 and 48 weeks. And when we looked across the study arms, it appeared that there were more infections in the arms that had received prophylaxis either. Most of them were in the arm with that had received nevirapine, infant nevirapine, but also in the other arms. So we were trying to think why that might be, and we thought perhaps it's not that the infections are acquired at this point, but perhaps they are acquired earlier, but we cannot diagnose them. So we looked at them in different ways. We tried to find specimens before the infants were weaned, and we looked at them with many assays. But the assay that gave us our answer was the droplet digital PCR, highly sensitive, hypersensitive assay that detects extremely low amounts of DNA. And we found that several of these infants were actually infected before the time of weaning. And their diagnosis was delayed because, most likely, because of antiretroviral prophylaxis. And this delay in diagnosis was longest in the arm that received nevirapine, where the infants received nevirapine. Intermediate in the arm where the mothers received combination ARVs, and the shortest in the control arm. So there were, in one case, it was actually a delay of 31 weeks between weaning and first detection of diagnosis. So these data really argue that the current recommendation by WHO is to test the infants at 6 weeks or more after breastfeeding cessation, and that may be interpreted that 6 weeks is enough, and our data clearly show that it's not. 7 of the 9 infants in that study would have been missed if we only tested them at 6 weeks, and then they told them they're not infected. These infants would go on to develop, disease and miss the opportunity to get early treatment. So, from our data, would suggest that it's several months after reported breastfeeding cessation that these infants need to be tested.
So, what did you guys think of the point of care testing presentation? I found it. Of course, being able to do early infant diagnosis and being able to have a test in front of you that you can get done in an hour, and you'd be able to start that child right away, is very attractive. But I was actually a little discouraged because it looked like testing at birth was not as sensitive as they thought. So, any thoughts about the point of care?
No, I agree. I think the sensitivity was lower for infants under 7 days, and the other issue I thought was the time it took to process. For 55 minutes to get a test result, one test result won't help you when you have 40 women in a busy labor room and they only spend 6 hours in the hospital before they're discharged. So when you're trying to implement it in a real world setting, it may not work. In a smaller health center, maybe where the volume is not as much, it might be able to help. But still, for birth testing, I'm not so sure if that's our answer.
It's too bad, because clearly it looks like the earlier you start treatment, the better the child may do. But we're having difficulty in getting the kids diagnosed early, and there's a lot of lost follow-up. I mean, you have experience with that, right? That the children, they're born to the HIV-infected mother, and then between the time they're born and 6 weeks, you lose a lot of kids before they even get tested.
Yeah, so there are issues in loss to follow-up in the PMTCT cascade. There are also issues in loss to follow-up of older children who are identified at centers. They may get their first test, but getting them back into care is an issue.
What do you think would make a difference? Do you think that if getting a test and having that test result there and being able to say, now we're going to give you something right away, we're going to start you in treatment, do you think that would make a difference in terms of being able to retain people?
I think it would, and I'm thinking this in terms of how the healthcare system is. The volumes are high, so for a family to come in for care, they really need to come feeling that they're getting something. Yes. Yeah. But if it's bringing you back in another 6 months and I'll let you know whether or not we'll give you something, that may hinder them from coming back. I would think that it would be great if we took the option B+ approach to treatment of pediatric HIV. Right now, with option B+, as soon as a woman is identified, she's initiated. Granted, there now may be some issues with adherence in the long term once they're initiated, but if we can strengthen adherence counseling at this initial interaction or an initial time when you actually have the child or the mother in front of you, you may be actually able to increase the coverage from the 23% that it is to higher coverage. The other issue is, I think we've had suggestions of other reasons why early initiation might be better for some of the older kids.
Yes.
There are the cardiac changes, and there's the share study, and
yeah, I agree. I think that you summarized it very well in terms of option B+ for children. I mean, lifelong therapy, as soon as you diagnose children, it looks like that would be potentially extremely beneficial. So I think that we've had both PMTCT, very exciting data. Triple drug therapy now has been proven beyond doubt that it reduces transmission to very low levels. There was actually a report from France where they reported no transmissions in women who were suppressed, and some exciting work in pediatrics showing that earlier treatment is associated with a variety of different benefits. So I think we actually had a very exciting session. So thank you very much, everybody, for watching.